Good morning. I'd like to start by thanking the organizers of the PAUSA 2022 conference, which is holding in Tunisia, for inviting me to give this talk. I apologize for not being able to be with you in person, but this was due to logistic problems that I could simply not overcome. I, however, hope that in the next few minutes I'll be able to give you as much of information as would be necessary on this topic. Prostate cancer is one of the most important diseases in the world. It's the most common male cancer, and definitely is also the most common male cancer in Sub-Saharan Africa. I bring you greetings from Ibadan, which is my base and which is where I am giving this talk from. Now, as I said, it's the most commonly diagnosed male cancer worldwide, and the information we have on prostate cancer on black men is mainly from US blacks. And what we know is that there's a high incidence of this disease in black men. They often present later. They have higher clinical indices such as PSA, stage, and volume at presentation. And after treatment, they have higher recurrence rates. The access to treatment is also poorer than in whites due to health disparity issues, and it's not surprising that there is a higher mortality. In Sub-Saharan Africa, prostate cancer represents 18% of all prostatic diseases in African men, and in our own institution, it represents about 12.5% of all new cases. It is reported that the incidence of prostate cancer in Sub-Saharan Africa is less than in US blacks, but we are quite clear that that is due to poor data collection and reporting. The peak incidence in our population is about the 7th decade, but we are beginning to see increasing incidence in younger patients, probably due to better detection techniques. The commonest cell type, like everywhere else in the world, is adenocarcinoma, and the various differentiation stages are as listed below, and you can see that most of the cases are poorly differentiated. As previously stated, almost 80% of cases in Sub-Saharan Africa present in advanced stages, with nearly 2/3 of them being metastatic at the time of presentation. The factors at play in these peculiarities are multiple, starting from the molecular biology of the disease in Sub-Saharan men in Sub-Saharan Africa. The genetics shows that various genes and the mRNA have been identified as playing a critical role, particularly those listed above, and also the stromal epithelial interactions involving the androgen signaling pathway and the EGFR-V3. Interestingly, immunology is known to play an important role from African American studies, and although we haven't done specific studies in Sub-Saharan men, we can surmise that the higher inflation and immune responses and the lower DNA repair activity reported in African Americans also play a role when we consider the biology of this disease. Other pathological indices that we've noted is a high PSA, and that in Sub-Saharan men, and that they often have lower testosterone and higher Gleason scores at presentation. Our studies also show that there is a high incidence of testicular atrophy in these men at presentation when bilateral orchidectomy is done. Peculiarities of our patients is that they are seen in large numbers. Most of them are poor. They often have significant comorbidity, and for them potency can be very important, which plays a role in deciding the kind of treatment they wish to have. At clinical presentation, aside from the late presentation, the disease often has an aggressive phenotype, but we're beginning to note that there is a mixed clinical course, with some patients doing quite well. On the social science aspects, there are cultural and belief system peculiarities which affect the awareness and indeed the treatment options chosen by patients. There is a lack of knowledge and awareness about the prostate, never mind the disease itself, and the inconsistent policies on health by various governments doesn't help. This certainly affects the issue of screening. We also look at the health systems that are really poorly structured in Sub-Saharan Africa, which results in poor implementation of the health policies, and the patients themselves have limited acceptability of orthodox care. In terms of disease management, 80% of payments are out of costs, with 65% of most cancer patients having to sell a family heirloom within 3 months of treatment. We continue to do mostly bilateral orchidectomy, although medical treatment is now beginning to gain ground. A few centers are now offering radical prostatectomy and radical radiotherapy, with active surveillance now beginning to come up with a better ability to screen and to follow on with the patients. We do refer a few patients abroad, especially those who have their relatives in foreign countries and who have the financial wherewithal. Otherwise, we know that the response to treatment is variable. There is limited long-term data on radical surgery and radiotherapy, and although the initial response to androgen deprivation is good, we know that within 6 months, within 80%, we know that 80% would have symptomatic improvement immediately, but the prognosis is variable, with survival rates depending on the grade of the disease. We're still running at 60% at 5 years, but those with spinal metastases tend to have a lower survival rate, with 58% being dead in 6 months. The 4-year survival is 80% in well-differentiated disease, whilst moderately differentiated disease do not do quite as well. Going forwards, this is a summary of our limitations to management, just summarizing what I've said before. It's important to note that we're still uncertain about the epidemiology and biology of the disease due to limited research and data, although more studies are being done. We cannot mention enough or emphasize enough the poor healthcare system and infrastructure, and the increasing brain drain is beginning to make the limited skilled personnel and interdisciplinary collaboration worse. It is also important to note that most newer drugs and treatment are not available, and industry support is severely lacking. Going forwards, we are now doing a few things differently. Essentially, we're increasing our public enlightenment of prostate cancer, and we are beginning to solicit assistance from corporate bodies and individuals. Importantly, governments are beginning to fund urology centers in Sub-Saharan Africa, and also increasing the funding of cancer treatment, which makes it easier for us to treat this disease. We're trying to stimulate more interest in prostate cancer research by government, NGOs, and industry, and also trying to develop novel ways of increasing prostate cancer detection, notably with antibiotic modulation of PSA. We're trying as much as possible to increase our cost effectiveness and acceptability of our treatment by involving the patients and their families in decision-making processes. We're using all the information gathered from above by presenting these at multiple fora and using it to improve urology care within the subcontinent. We're also trying to design other community-based projects that will go around making sure that the prostate cancer is seen as one of the major diseases on the subcontinent. We're including this in the curriculum of our residents and medical students, and inserting the disease in various health reforms and awareness programs in the various countries. The way forward is for us to develop more homegrown policies on the disease. We need more research, particularly of the translational type, to try and improve knowledge of the disease. We must improve our data collection. We must continue to engage government for increased funding, and also engage the NGOs and industry to support urology in general, but urologic cancer in particular. It must emphasize the need for availability of drugs at affordable prices, and ensure that new drugs are tried in Africa prior to approval by our various bodies. Capacity building in all oncology specialties is important, and we must try as much as possible to retain our health professionals. In the end, we need to increase funding of cancer research and treatment, and we need to know that men also require to be considered as a priority in cancer awareness products. Finally, we need more of the urology training centers, in addition to those in Ibadan and Dakar, and also to ensure that we can turn out more trained personnel. I'd like to end by acknowledging my co-authors, my other clinical colleagues who provided the information I presented, my co-researchers, and my research staff. I thank you very much.